You're listening to the Move to Value podcast, powered by Chess Health Solutions. The Move to Value podcast is dedicated to helping healthcare providers understand and make the transition into value-based care. We do this through conversations and the sharing of innovative ideas with practitioners, experts, and leaders throughout the healthcare industry. Our mission is to sustainably transform the healthcare experience for the patient, provider, and care team by cultivating a value-oriented, compassionate, and health-aligned community. Today we're here with Mark Dunnagan, Chess Vice President of Health Informatics, to talk about interoperability, what it means, why it matters in healthcare, and how better access to patient data for the entire care team will lead to improved outcomes for patients, all at a lower cost. Mark Dunnagan, welcome to the Move to Value podcast.
Thanks, Thomas. Glad to be here.
So, Mark, today I want to talk a little bit about interoperability with you. So, can you first off explain what interoperability is?
Well, in the simplest terms, interoperability, at least in my travels, is a metaphor for a conversation. Think of it like provider A wants to talk to provider B about patient Mark, and it's a means of making that happen.
And why is interoperability important for healthcare?
Well, I think in line with the metaphor of the conversation, I think 50, 7,500 years ago when you only had one physician and they knew everything about you, maybe it made sense. But in modern times with, the various ways of receiving care, physicians don't know everything about you, and there's no way for those forms that you fill out, unknowingly so, when you go to the physician's office, can express everything that has happened to you. Interoperability is the key to that. Again, to know where Mark's been and what happened to Mark and why it may have happened.
Well, Mark, can you share a real-world example of how interoperability provides value to healthcare?
Well, I can, and it's part and parcel of what we do on the value side, literally every day. We receive what we call ADT feeds. It's basically a notification that one of the patients under our care has recently checked into a hospital, or has recently, depending on the depth of the ADT feed, perhaps been seen out of network or gone to specialty services or whatnot. But that ADT feed, that notification that one of the lives that we care about has been touched in some way by healthcare entities around us, gives us information that we need to know to intervene appropriately, that if someone has been discharged home, that we can, abide by our contractual obligations to check in on them, that if someone has been seen out of network, perhaps, seeking high cost, high value services, that we can make sure we understand what and why, and again, provide, appropriate care management or interventions to help them with that. So again, that is part and parcel of what my teams deal with every day, and a huge part of the services that we provide. Without that form of interoperability, we would struggle to provide the value that we do.
That's fascinating. So we've established that the need for patient data exchange between providers is very important. How can we continue to close this information gap? How can we make this a better exchange?
There's a million answers to this. I think the foundational elements to make interoperability real are there, and to be honest with you, have been there for some time. Now, granted, what becomes interoperable, meaning the data that we need to share, continues to expand. Of late, care plans, and then the ingestion or the sharing of perhaps behavioral health information. The breadth of the data continues to expand, but the notions of interoperability have always been there, as far as the structure, the shape, if you will, of the data and how it's exchanged, and then kind of the language, the nomenclature, the codified values. There are at least examples and standard terminologies that can be used for most everything. I think, for me, the struggles, if you will, continue to be around, adoption, and certain EMR technologies take certain liberties with how they interpret those standards. Certain entities, I won't point fingers at payers, but let's just say if it were a payer, perhaps they don't necessarily communicate things in a timely fashion or in a structure that's, so easily recognized. So I think the technology has existed for some time. I would say that, there's a need, if you will, to expand upon adoption of those technologies and for everyone to kind of agree on certain interpretations.
So, as technology advances and we begin to see real-time interoperability, how can that improve outcomes?
Well, I think, again, the example of the transitional care, that ADT feed I referred to is probably, one of the better examples of, if we are to intercede and prevent a costly event or know that someone's condition has degraded to the point where they might be at risk for a fall or for an emergency room visit or an extended stay in a hospital, that's where value-based care, where care management, some of the services that we provide can intervene and prevent, further degradation of healthcare or bind together these disparate healthcare teams where, a primary care provider and a specialty, maybe even a skilled nursing facility, all need to kind of coordinate together to make certain things happen to the betterment of the patient. Knowing that information as quickly as possible is completely vital to what we do. I would say there's also a very reasonable example where the timely access to data is important to us as well with respect to, a big part of value-based care is quality measures. And quality measures basically says, you are judged by your ability to conduct cancer screenings, let's say. And in order for us to know that a payer has recognized that gap has been closed, we need timely access to claims files. And if we can't get that timely access, although we can say all day long that, look, we can see that data in the EMR, we know that gap has been closed. If that payer doesn't necessarily recognize that, if we don't get that file back and they say, hey, we recognize that this has been closed, we suffer. It may mean that we don't get paid in time, which means that we aren't able to pay our payers in time, or that we spend time trying to close the gap where we might have spent that time somewhere else to the betterment of another patient.
So you touched on this a little bit earlier, and I was hoping that you could elaborate a bit more on some of the barriers that you've seen to interoperability in healthcare.
Before I speak to the barriers, I think I would just reemphasize the fact that it's my impression that the technology to support, what I would say is true interoperability, true bidirectional conversations about the health of a patient exist and arguably have existed for some time. I mean, they have evolved and they will evolve, but I would say the baseline technologies exist. I would say the barriers are in interpretations of the standards and maybe the implementations of certain technologies where, certain vendors, let's say, take some liberty, like for those of us that know the dirty word of CCDAs and what those are, those are XML constructs that are kind of the envelopes or the trains that carry the data, the train cards that carry the data between systems. They have both a human readable and a machine readable section. And, it's completely legitimate. It's a well-formed document if a lot of the valuable information we're looking for is buried in textual evidence in the human readable portion of it, but that's not necessarily machine readable. So, it comes down to context and interpretation of some of these standards that I think is a continued barrier. I would say that there are some creative forms of information blocking. Again, I won't necessarily point fingers at any particular vendors or any other entities, other than to say that, even in our world, the dragging of feet, the less than timely response to requests for additional information, or let's say less than cooperative integrations with on-site systems where, it's a kind of a could versus should, or would we, where politics, where, the lack of willingness to share information based on, certain entities maybe fighting for footprints in certain geographical areas gets in the way of an altruistic exchange of information to the betterment of the patient. And again, forgive my political correctness, but, politics and revenue do come into play in this world, and I think they are barriers to true interoperability.
So the next question was about standardization, but although you've touched on that with your previous reply, what else can you add about the need for standardization?
But I would just affirm the need for standardization and standardization and flexibility, or maybe the better word is extensibility, meaning you have a set of standards, but you agree that they must move and evolve and extend themselves as kind of the data that we take in, as we're moving towards whole person care, treating the whole person and expanding to care teams, not just providers, but maybe expanding the definition of providers beyond the traditional, it's a doctor or a nurse, that the standards must expand. But standardization itself is absolutely necessary. And even after all this time, I could say that I've been in interoperability since it started. I don't want to give away my age, but it's substantial that, diagnosis and procedure codes, I think, are finally where we need them to be. But, we run into challenges every day with, labs, with medication, with textual evidence that we know is indicative of some other diagnoses that are probably hidden somewhere in there. And there's a number of technologies that can assist with that. But nonetheless, it's not readily apparent. There's other hoops you have to go through to get that. So, the more standardization that is put in place, the more the marketplace itself agrees that, this is the way we must communicate that about Mark, the better for all.
And do you see value-based care demanding a greater push for open data exchange?
I do. I mean, again, it probably comes down to the definition of value, but I would say that value-based care is well on the continuum, or certainly a lever to be pulled in what I would call whole person care. And when you start to think about taking care of the whole person, mind and body and maybe even spirit, if you will, that brings about the need to talk openly, and where some of these barriers I talked about before, whether they be geographic or business related, hopefully not political, but it's, sometimes that comes into it too, that those barriers, are removed. And, it's interesting, we start to talk about barriers, and this is going to be maybe a partial answer to some of your other questions, but I can remember I was chief architect of one of the larger statewide HIEs, and its mandate was only for state paid services. But when the COVID pandemic hit, there was an urgency to those that were only sending a piece of their health records. And again, think about all the hospitals in the state, sending like only certain portions of their record, that everyone opened the doors, opened the floodgates, and sent everything in response to what was perceived to be the greater good. And that was monumental. And I would hope that it wouldn't take another disaster of that proportion for us to say, hey, it's the right thing to do.
Agreed. So, Mark, I appreciate your time and this conversation today, but I do think that there's more to this discussion. Would you be willing to stick around for a bit longer to answer a few more questions?
Yeah, I'd be glad to.
This is the Move to Value podcast, powered by Chess Health Solutions. We hope you have enjoyed this episode. If you would like more information about this and other episodes, you can head over to movetovaluepodcast.com to check out all of the available resources. If you're interested in continuing to hear about value-based care and how it impacts you, you can sign up for our email notifications or subscribe to this podcast on your favorite podcasting platform. Also, we would love it if you would share the Move to Value podcast across your networks and leave a rating or review. Thanks for listening.